Welcome, everybody. My name is Mike McKee. I'm a professor here at the University of Michigan and also Michigan Medicine. And I am delighted to have our next provider webinar series that's hosted by MDisability. And before we go and introduce our guest speaker, I want to just provide a little bit more information about this MDisability provider webinar series. It's hosted and it's really designed for primary care clinicians and also for other health professionals who are interested in disability health. And this is really intended to improve the care for patients with disabilities. So we offer this generally quarterly, so please be on the lookout for future topics and also webinars. We generally try to cover a whole bunch of different topics that are relevant for disability health. So the other thing I want to also just pivot is to first acknowledge that we do have funding support for CART services, and that is with Dr. Fisher. He has already provided us with some funds to support this, and we're very grateful for that. Dr. Fisher is a 1960 University of Michigan Medical School graduate, and he has been a long-term clinician around in this area. And so we are very grateful for his support. And also we will have interpreters, and they're going to be provided through the interpreter services, and we're very appreciative of their support as well. So if you do need CART, please go down to the bottom of the Zoom window. You'll see a caption you can select that. And also the interpreters should be available if you can select their box and be able to spotlight them. So now I want to introduce our speaker. I'm really delighted to introduce my friend and also an incredible ENT doctor, Dr. Chad Ruffin. He is really disrupting traditional hearing healthcare, and it's really for the better for all of us. And so he is born with severe hearing loss, and Dr. Ruffin is an ENT doctor. He also performs cochlear implants, and he is a really strong advocate for adults and children with hearing loss. In addition to working one-on-one with patients at his clinic in Seattle, Dr. Ruffin and his team perform innovative research and advocacy for the hard of hearing community. He's going to share some really unique perspectives on hearing loss management, and he is going to really leverage his expertise not only as a patient with hearing loss, but also a physician who cares for people with severe hearing loss. And he's going to highlight why hearing loss deserves greater attention in primary care and explore often overlooked sequelae that impact the quality of life and discuss practical strategies for collaboration between primary care providers and ENT specialists to ensure comprehensive care for these individuals. So this session really is going to be, I think it's going to be a great one and inspire us to hopefully approach this in new ways to treat hearing loss that just goes beyond just simply thinking about amplification, but really focus on how we can improve their communication, mental health, and overall well-being. So with that, I'm going to turn it over to Dr. Chad Ruffin. Thank you so much.
Thank you, Mike. Thank you for, Dr. McKee. Thank you for that warm introduction. I am very honored to be here and talk about this topic. It's very near and dear to my heart. I've been in practice for about 7 years now, and mostly out in Seattle. This has been something that has been kind of evolving how I approach hearing loss and how it's changed from how I was trained. This talk is geared for an understanding of the effect of permanent hearing loss and comorbidities and how we can deliver and improve delivery of a highly fragmented care team. It's not really geared to be an overview of ear disorders for primary care doctors. I'm not really talking about ear exams and stuff like that. I'm talking about things that I see that are missed in the community and opportunities for improvement. Hearing loss is vastly undervalued by society. We're coming to a better and better understanding about how hearing loss affects the whole person. We have lots of research on this, but we don't really translate that research into how do we make people's lives better? How do we not just focus on improving the speech perception score and actually improve the day-to-day achievement, connection of people with hearing loss in their relationships and all of that stuff. So that's what I hope to work on some today. My background. So the main thing I want to talk about is beyond the clinical stuff. I've done a couple of research fellowships in bottom-up processing of how speech and music are encoded at the ear level, at the auditory nerve level, and then a second one in cognitive changes associated with hearing loss. I want to highlight the fact that I'm the first physician born deaf to become a surgeon with cochlear implants. And I don't want to do that as a bragging thing. Going through this process was incredibly difficult. It is the hardest thing I have ever done, bar none. And in going through that, it really highlighted gaps in care, things that I had to learn about my own hearing loss that no one ever told me. I had to put all of this stuff that I learned in my research fellowship into action. And so when you're an ENT and you work in a quiet office or an audiologist, what you see in the exam chair can be altogether different from how people are interacting in the real world with their colleagues and stressful situations, noisy situations, and how they navigate the cognitive load associated with hearing loss, how they build and work on their soft skills. So the first physician born deaf to become a surgeon is actually a woman who used ASL to communicate. This is Dr. Angela Earhart, who's a maternal fetal medicine specialist in Houston. So the main point I want to start off with is hearing healthcare delivery is terrible, is absolutely awful. It's highly fragmented. The identification and management of pediatric hearing loss is okay and is improving. Adults is poor, but it is improving. And I'm going to share this statistic with you that is kind of shocking. It's the hook for the session. If you need a prescription hearing aid, all the educated people in this audience only have about a 20 or 30% chance of having that hearing aid appropriately fit, even by a doctor of audiology. And if you look at that, your chance of being told how to use that technology at the level that I use my own technology is about 0. Secondly, hearing loss is the #1 modifiable risk factor for dementia. And if their people aren't wearing hearing aids, how are they going to manage this risk? The second thing is hearing is more than hearing words. You can hear a smile. There are many other characteristics in the voice that are communicated through hearing, and as well as vision. But hearing plays a role in how we tell people what we really mean, how we sense and express love and vulnerability, how we express frustration and navigate conflict, and how we find our way back to understanding and empathy. Hearing loss deeply affects how we meaningfully connect with each other. So when we say hearing, we are really talking about communication, and we often lose sight of this salient point. So our objectives today are to talk about why this is important for primary care providers and highlight some of the sequelae that are overlooked but relevant for quality of life, and identify critical vulnerabilities in the hearing healthcare delivery systems. This goal is not to get into the weeds, but have a little bit more of a holistic understanding of hearing loss and identify high risk for treatment failures. So quick facts about hearing loss. About 20% of Americans have at least a mild hearing loss in one ear. You can recreate that effect by putting a thumb in your ear and blocking your ear canal. If you have hearing loss in a mild hearing loss in one ear, you're about 4 times more likely to fail a grade if you're a child. 75% of the prisoners in the prison system have at least a mild hearing loss. So this has a cascading effect. About 0.5% of people, around 1%, have severe hearing loss. Severe hearing loss means that it impacts the acquisition of speech and language. People with hearing loss are more likely to be lonely, and that loneliness is a greater of a risk factor for mortality as smoking a pack of cigarettes a day. You're more likely to be underemployed. So the employment rate for deaf and hard of hearing people is about twice the general population. Elderly people have greater healthcare expenditures when they don't receive treatment for hearing loss. And we'll talk more about dementia later. So where are some of the failures? Even in the UK, where we have the NHS and people don't have to pay for hearing aids, only about 20% of hearing aid candidates receive a hearing aid. And it's delayed by about 10 years in most people. There are a lot of factors that impact that. And that really has been stable for the past 40 years. It's probably taking an uptick now because there's more awareness of dementia and its effects risk with untreated hearing loss. We already mentioned that having a hearing aid that is appropriately fit to best standards does not happen very often. Fewer than 5% of adults with a severe hearing loss who would benefit from a cochlear implant ever receive one. One of the real problems for tying all of this care together is that audiologists are incentivized to sell hearing aids. The Social Security Administration Act prohibits audiologists from getting reimbursed by Medicare for providing counseling for hearing loss, like really in-depth, in-the-weeds counseling. Only speech pathologists can receive reimbursement for that. So that is statutorily limited. ENTs in private practice just care about selling hearing aids for the most part, and ENTs in academic practice are more interested in surgery. So these things tend to fall through the cracks, what people really, really need. There's a great shortage of interpreters and support for signed language. I think that there is a great bias against sign language in the academic literature when the research is performed by hearing people. There are tiers of what we would consider sign language. It's another whole other discussion, but not everything signed on the hand is a language. So this fact is, we know this is something that has been robustly shown over multiple studies over 40 years. We can give someone a hearing aid or a cochlear implant, the quality of life will improve. But the quality of life, the improvement in that quality of life is not at all correlated with the improvement in speech perception. How many more words you get with that hearing aid or cochlear implant is not at all correlated with how satisfied you are. It probably has to do with how many other things. Some of the emerging research is connected with how well we can perceive emotion, really how well we connect with people. And so it's a mind-blowing thing. And I can't talk to patients about this. I mean, they just don't get it. Many patients want the best hearing aid, they want the best cochlear implant, and they don't really understand that some of the reasons for your success isn't always going to be hearing 1% better, but being able to interrupt a 200-person Zoom and saying, hey, you know, the sound quality here isn't great. I'm sure other people are having a problem hearing too. Can you fix this? So being able to advocate for yourself and recover from misconnections is really important. So as I mentioned, everyone is focused on speech. How do we improve that speech perception number? Well, let me back up, sorry. Most people start with the ear level description. We're going to start from a top-down approach. What are we really trying to improve? Communication. And everyone focuses on speech and the speech perception number. So when we talk about that, we're talking about the individual syllables or the phonemes in words. We're talking about the actual words themselves. But in the speech signal, in the communication process, there's all kinds of other things that we pay attention to. For example, indexical cues. These are things about the speaker. Can you hear a smile? A smile, hearing that smile is an indexical cue. You can tell things about people's gender. You can tell about their emotion, their energy level. You can tell if you're being hit on by someone, you know. You can tell where they came from, what their education level is, just how fit they are. You can tell who they are. And you can do all of this rapidly, on the fly, within a few seconds. You don't have to hear a whole lot. So we use speech cues to figure out what people say beyond what's explicitly stated. This is pragmatics, what's implied. And we use a ton of other speech cues as well, like non-lexical speech, the hms, the ahs, that indicate engagement. or skepticism. We use nonverbal cues, like what people do as a result of their sex or their gender expression, their facial shape, their features, their expressions, how close they're standing to you. Are they folding their arms up? Where they're looking. All of those, you have to incorporate that. And to figure out what people really mean, you bring in context clues from the environment, the current situation, things that you've talked to about the person in the past. You, if someone is from East Asia, you might talk to them a little bit differently than someone from America. And then you also use, individual characteristics. So you're doing this to put yourself in the other person's shoes. That's empathy. And that's what we call, the academic description is theory of mind. And we use this to go back and forth, and that is to exchange goals and figure out what the other people want. And that's what we call language. So when you tell your patients, like your patients, pediatric patients, well, we really want to improve Johnny's language outcome, speech and language, hearing parents, and including me, when I was younger, would think, oh, we're just talking about how well someone talks and if they can do okay on a language test in school, academic performance. What I'm talking about really is what language is. And that is a failure of understanding of many, many people and how we do this. So then, not only do we have to do this taking in the information, we have to do it expressing it too. And if you're in a meeting or something, you have to multiply this slide times all the other people in the meeting. So I had a patient who is a lawyer. This is a long time ago, and he had a cochlear implant. And he scores very well. He maxes out on the best speech perception measures that we can throw at him. But he can hear everything in quiet in like a meeting. And I asked him, I said, if you were in a meeting and you can hear everything, you don't have to ask anyone to repeat things, and you're trying to negotiate a contract, can you do that? He said, no, because I'm spending so much time thinking about what people are saying, I can't think a couple of steps ahead and plan what I need to say. So for you guys with normal hearing, this is most like translating a foreign language while you're in a restaurant. So when you are a child and you have hearing loss and you can only hear a few feet from your ears, think about what this means for social learning and soft skills. It really, really impacts them. So the bottom line of this slide is, here we go. The bottom line of this slide is people with hearing loss are in the weeds. They're not doing all of this other stuff on the, They're not doing all of this other stuff on the slide. They're trying to get the individual words and sentences out of speech. They're basically doing this. This is something that I show my patients nearly every day when they have severe hearing loss. So hearing occurs in the brain, and that previous slide that I just told you about is basically what cognitive load is. You're working so hard to fill in the gaps that you're just tired and you don't have that much mental reserve for everything else. And a lot of people will say, well, if you can speech read, if you have a great view of the face, you can replace all of these other you can see all of these other visual characteristics, and hearing loss really shouldn't be that much of a problem. That's just simply not true. So vision doesn't mean you always replace what you can't hear, and if it's visible on the face. First, if you're really young or really old, you're going to rely on vision more. Only the young adults have great hearing enough where they can pull this off and get all these indexical cues and other cues just through the voice alone. So when you are older or younger, you require on seeing things, but just because you can see things doesn't mean that they're going to be processed. Identifying things and actually incorporating them into your executive functioning are not the same things. So this is just a slide on the description of the brain. Is the speech and language areas have projections to many other parts of the brain, and there are cognitive risks. Cognitive risks associated with hearing loss depending on the age. So if you have a congenital onset hearing loss, you want to intervene in that with the 136 benchmark. So you want a newborn hearing screen within 1 month, confirm at 3 months, intervene at 6 months. That's because the critical period for speech and language development is from about before birth to about 6 or 7 years of age. Those first few months are absolutely critical. We can tell the difference in long-term speech and language outcomes a decade later with just a few months of delay. This can lead, like prolonged delays of not giving a kid language, whether it is oral, listening and spoken language, or sign language. That can lead to language deprivation, delayed motor milestones. So language deprivation is a complex issue of executive functioning where kids just don't have language and their brains don't function. They can't just function in everyday life. And as you get older, there's a higher risk of dementia with adult onset hearing loss. And that is, like I said, hearing loss is the #1 modifiable risk factor for dementia. I'm going to skip over this. I'm just going to briefly say that we're now starting to understand how cognition affects bottom-up processing of speech. And everyone's brains are different, and we will probably in the next decade get into precision medicine based on brain characteristics. I also want to say that language acquisition is not guaranteed with sign language. So there's a huge controversy, not really huge, it depends on who you talk to. There's a controversy between listening and spoken language approaches versus sign language and congenitally deaf children. And I just want to say that just because you give a kid an implant doesn't mean they're going to get speech and language. There's still about a third of them who are going to be delayed. And if you give those kids sign language, that doesn't mean that they're going to actually use it. Kids have, if you look at MRIs of non-syndromic hearing loss, there's about a 40% rate of other abnormalities seen on those MRIs. So now we start from top down. We're going to go to the bottom part. So the inner ear, the cochlea, is a analog frequency analyzer that provides robust information for the brain to perceive speech and quiet and noise. Those are two different functions. To appreciate music and to segregate sounds into auditory objects that the brain can selectively attend to or suppress, and also to localize sound. Everything else about the ear exists solely to get sound or conduct sound down to the cochlea, the inner ear. And it does make it a little bit louder. When you have a conductive hearing loss, problems getting sound down to the inner ear, like earwax, a failure of development of the ear canal, holes in the eardrum, problems with the middle ear bones, those are the issue with just getting sound louder. That's a conductive hearing loss. If you make sound louder, for the most part, people are going to be okay. When you start getting into the inner ear is when you start getting into issues of clarity, and just making things louder doesn't make things okay. Mixed hearing loss is when you have issues with both. Some examples of that would be some syndromes. You could have, most common cause is probably otitis media, where you have middle ear issues, and then you have infection, bacterial infection of the inner ear. So how do we treat hearing loss? The goal is basically to provide access to speech and language. Excuse me. We do this most commonly with with hearing aids. Hearing aids basically amplify sounds and make things louder. They are getting better and better at removing the background noise and the speech signal. Cochlear implants are different. That's what this illustration is. That's what I have on each ear. And a cochlear implant is an electrode implanted in the inner ear, the cochlea, and it bypasses the damaged hair cells and directly stimulates the auditory nerve. The external part is a processor that sends sounds wirelessly across the skin. There are a variety of different processors. Sign language is another way that you can provide access to speech and language. I think the biggest point for people to understand that baby sign is not sign language. Signing what you're saying word for word is not sign language. When you're doing that, you're not focusing on language, which is something on the face as well. And a lot of studies conflate those two things. It's not SimCom, which is signing on the hands. And so sign language is an independent other language that has its own syntax, grammatical structure, rules, and all of that. When amplification and isn't great or cochlear implants don't have a great outcome, you can use remote microphones. I put a wireless speaker on the person of, wireless microphone on the person of the speaker, and it streams directly to my ears. Very helpful. There are captionings where you see on this today, CART. This is human captioning. There are auto captions, like you have the speech to text apps, like, or very, how you get TikTok and Instagram videos captioned. The auto captions are faster. They're often can be more accurate, but human captioning has better things on it for segregating speakers, indicating who's talking and stuff like that for multiple meetings. That is very helpful. Oral rehabilitation is how we tell people how to live with hearing loss. In my view, I think this is very poorly done. It's basically, when I see this, it's examples like, sit with the light in front of you so the face is fully illuminated, and like just kind of like really blah stuff like that. Has nothing to do with, like, how do I navigate pillow talk with my partner? How do I if I'm at a restaurant, like, how do I talk to someone? What are things that I can actually say to get someone to go on a date with me? I can't hear anything else. We don't talk about that kind of stuff, I don't think.
I can hear another conversation.
Oh, whoops. So just to give you an example of why cognitive load is an issue, I'm going to play very briefly a short sample of normal speech, non-processed, and the second sample is going to be processed to sound like a cochlear implant.
I can hear another conversation through the cordless phone. She relied on him for transportation.
He was an ordinary person.
Yeah, so you can see that it's an impoverished signal. Cochlear implants do not restore normal hearing. That noise that you hear is kind of filtered out by the brain, but the decreased pitch, the flat pitch, not being able to hear those indexical cues, that's a big deal. So we're going to shift into opportunities where you can see how PCPs can be a crucial part of the care team, because care is so fragmented. It's really useful to circle back and check in on patients. So having a child with a disability is an overwhelming thing for parents with a hearing disability. It is something that spills over and affects siblings. So this is something to keep in mind when you are talking with parents of kids with newly diagnosed hearing loss. So I think one of the things that primary care doctors can do is to maximize the quality of life in other domains so that you can impact the overall quality of life. So if there are like issues with anxiety or depression in mom and dad, or sibling is not happy with things, maybe they have ADHD, it's important to treat that family together, and so that the entire family goes through this process and they do better. So some of the risk factors for pediatric hearing loss that you can't really do a whole lot about: genetics. These are both spontaneous mutations as well as germline mutations. There are syndromes, malformations. There are torch infections, like CMV is a big cause of pediatric hearing loss, prematurity. Modifiable risk factors, prenatal care. Even though we're talking about risk factors for pediatric hearing loss, to minimize the cascading effects of hearing loss, early intervention is crucial. And we talked about that 1-3-6 rule earlier. Addressing nutritional deficiencies. minimizing childhood infections with vaccines, minimizing noise exposure and exposure to ototoxic medications. Symptoms of pediatric hearing loss. They don't react to noise, they don't startle. This, if mom thinks that there's hearing loss, that is hearing loss until proven otherwise. Speech delay and cutesy mispronunciation of words. So need a hearing test for that. Kids who are getting frustrated and isolated at school, who aren't engaging with their peers successfully. If there's any issue with executive functioning, poor academic performance, difficulty with math, following directions, anything like that, we should get a hearing test and verify that hearing and vision are doing okay. Just talked about that, daydreaming. Management for pediatric hearing loss. So pediatric hearing loss is a high complexity hearing loss. It's something that needs to be seen by a pediatric audiologist and an ENT. Ophthalmology needs to make sure their eyes are doing well. So these are the primary people involved. Our goal for this is to ensure language and academic development. And there are other specialties may have to see depending on if there are other syndromes, malformations, infections, stuff like that. As I said again, time is of essence. If it were my child and the newborn hearing test was failed, I would be bam, 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 bam. I don't want to draw an analogy between, I'm not going to draw an analogy between other illnesses, but I would treat this as an urgency if this were my, my child. We need to mobilize the educational team for preschool, early intervention, and elementary school. And this most often includes the audiologist, the speech pathologist in the school. Educational audiology is audiologist who works in the school setting to make sure that the child has access to speech and language and instruction, and also special education. So children, most of you are probably aware, children have like rights under the multiple federal laws, but most importantly, they need like a 504 plan, special ed plan. Role of primary care. So all of this is like super fragmented. I think that it's very valuable to check in from time to time with the family, bring them back, make sure that everything is being addressed. I think that the number one thing that you can do is probably that, and also to emphasize urgency with the family. You have to explain to them that it's not about speech and language. You can't use those terms. You have to make something concrete. Johnny's not going to make as much money as you are. They're not going to do as well. Their achievement's going to be worse. We can tell, like, if you delay care by 6 months even, we can tell that long term. So you have to give this in a way that people can understand. So we already talked about this. I'm going to add on to, sorry, I should have taken OTC hearing aids out. That is not a thing for children. The gene therapy, that's one thing that is coming up. There are extremely promising gene therapy trials that actually may well cure certain types of genetic hearing loss. And those are just coming out right now. So let's shift into adult onset hearing loss and presbycusis. By adult onset, I mean outside of adolescence, and presbycusis is probably over 45 years of age. More than 2/3 of people over the age of 70 have some degree of hearing loss. Over 10% of people have dementia. The risk for dementia is twice as great for those with hearing loss. And 45% of dementia cases are thought to be preventable, and hearing loss is the #1 modifiable risk factor. So I want to talk about the non-modifiable, these risk factors. So hearing loss is super undervalued. And I'm not making a political statement here, but if you look back to the beginning of the COVID epidemic, there are the people who were most vocal about anti-masking are the people who have the greatest risk factors for undiagnosed hearing loss. They are older, than 45 usually. They're male, they're white. You have non-white people have melanin in their inner ear that protects against hearing loss. White, blue collar, noise exposure, and rural. And I actually wrote an article to highlight this, and none of the papers would pick it up. It was reviewed by a Pulitzer Prize finalist. Anyway, hearing loss is really probably way underdiagnosed. I don't know the stats on this, but so things that you can do about it, noise exposure. So many kids walk around today using earbuds, and they crank up those earbuds to block out the outside noise. If they're going to listen, they need to use headphones to block out outside noise. Smoking, blood pressure, all of that stuff is kind of like, that makes common sense. So there are 5 ways that, sorry, go ahead, Mike.
Yeah, Dr. Ruffin, I just wanted to let you know, there is a question that we have. It says, how do you suggest primary care providers navigate parental resistance to cochlear implants? For example, if the parents are deaf and they want their child to remain in the deaf community.
I would give them that information. I would not, that's the information for the parents to make with the child. If the child is having normal language development, that's what we're doing. They're connecting with their family. They're connecting with other people in the deaf community. Like it or not, you can't force people to do what you want. And cochlear implants don't solve things. They make it better, but they don't solve things. And you have to respect people, their choices. I had a patient who came in with tinnitus, and she was a capital D deaf patient. Had a hearing husband, 1 deaf child who signed, and 1 hearing child. And I could tell, I don't sign, but I could tell that the deaf girl was doing great. She made eye contact. She was communicating with her parents. She was doing great. And the nurse asked the same question that this person asked. Why didn't I bring up cochlear implant? That's not what they were there for. The kids' language development's fine, so that's that family's decision. So symptoms of adult hearing loss. So adults, these are not being able to hear is kind of an obvious symptom. So I'm going to talk about things that are not obvious. Not being able to participate at the dinner table. See a senior citizen, they're quiet at the dinner table, especially if they used to be pretty engaged. That's probably hearing loss. Difficulty hearing in background noise. I can hear just fine. I just can't make out things like I used to. So the question I asked, I'll get to that on the next slide. Ear pressure. If you have a blocked or a congested ear, like a blocked ear is sudden sensorineural hearing. A blocked ear, those words, and is painless. Normal ear exam is a sudden sensorineural hearing loss until proven otherwise. But anyway, ear pressure is, even in both ears, is often not TMJ. It is hearing loss. Having ringing or buzzing noises in your ears. A correlate to tinnitus is hyperacusis, similar neurological mechanism, but very different patient experience, is pain or discomfort with louder sounds. Anyone who comes to you over the age of 45 and they say they can't hear because of wax in their ears, they need a hearing test. If you have someone coming in with normal hearing and, if you have a young person, like a 20-year-old coming in, they have a wax, ear full of wax, they're just gonna say, I have some pressure in my ear. You take that wax out, it's totally fine. They're never gonna say, almost never gonna say it's a hearing issue. So, these are the 2 questions that I ask. These are like, if you ask these 2 questions, you will pick up on most hearing loss. Like I would say 90%. I actually don't know that because I use other cues like visual cues, and we'll talk about that in a minute. So how well do you hear in background noise? How well can you hear people talking when other people are talking? Like if you go to a restaurant or a bar. Does anyone comment on your hearing? For those that I suspect of having severe hearing loss, this is screening people into the high complexity hearing loss. Can you talk on the phone easily, just using one of your hearing aids in either ear? So if you can't talk on the phone normally, you have to stream to both ears, or it's difficult. you're in a high complexity hearing loss category, and that is someone who should be referred on to an ENT. I once, in physical exam, things to look at, I once identified a cochlear implant candidate sitting in the waiting room because in my practice, I'm an independent practitioner, and I actually go get patients to the waiting room myself. And I called one patient's name out, their head whipped around. They couldn't tell where I was coming from. I knew immediately that they were single-sided deaf and probably needed an implant in the other ear. And it was true. So when you're talking to someone, you can look at them, watch their eyes. There's usually, if they have a significant hearing loss, they can be looking through you, and there's a slight delay in when they respond. So we're talking about like the death stare. The other thing that people do is they'll turn their head toward you. And if you're in a quiet room, having someone ask for a repeat more than once, and you're both speaking the same native language, that is hearing loss. Need a hearing test, especially if the person's over 45. It's not normal to have to ask people to repeat things in a quiet room when you're speaking clearly. So treatment of hearing loss. Not everything needs hearing aids. Not everyone's a great hearing aid candidate. Observation is a very valid thing. That is not untreated hearing loss. You're just watching, getting a hearing test every couple of years. Amplification. So I want to say we have prescription and OTC hearing aids. I don't think OTC hearing aids are a great option for most people. For people who are super educated, super techie, they can go and, so, not educated, super literate is probably the better word. Super techie, and they can afford making a mistake. OTC hearing aids may be perfectly fine. There's a lot of junk out there. They're not all the same. People are taking advantage of the regulatory environment. So I generally prefer to steer people to prescription hearing aids. Hearing assistive technology is the remote microphones that we talked about earlier. So the most important thing in the treatment of hearing loss, adult onset hearing loss, is preventing dementia. One of the things. The most recent data that we have shows that if you, in 2023, the ACHIEVE trial, which is a 3-year randomized controlled trial, shows that if you give a population of people with hearing loss hearing aids, their risk for dementia doesn't go down. However, they pre-stratified the people with hearing loss into 2 groups: those who had risk factors for dementia, like diabetes, smoking, obesity, all of that stuff, and then those who didn't. And the cognitive decline in the group that had the risk factors for dementia that risk for dementia was halved when they were provided hearing aid and hearing aid treatment, hearing treatment. So what I do when I talk to patients is I tell them about dementia. I say, especially if they have cardiac, other risk factors for dementia, I tell them, you got to get a hearing aid. Like, you can't hear in background noise. You're having to ask people to repeat things. And people are commenting on your hearing. Comorbidities. So primary care has a special role in coordinating all of this care and circling back to patients. So comorbidities that are associated with hearing loss, so cardiovascular, microcirculation, adult onset hearing loss, that is, need to manage cardiac risk factors. So paranoid thinking, there's multiple studies out there on this. I think this is not an evidence-based statement, by the way. But I think the paranoid thinking is like, you're isolated from other people. At work, you have to learn to work with people who may discriminate against you. So people are on the defensive a lot. And that may be the issue with some of this paranoid thinking. You have anxiety and depression, so loneliness. All of these are issues that can be addressed by primary care doctors. Impoverished soft skills. What you see in the exam room, I don't care how gregarious they are, is not how they perform in the real world. You have to ask about their job performance. Are you meeting your goals? Do you feel like you're listened to at work? And there are different, you can refer people to speech pathology. They can work on cognitive issues with hearing loss, mentorship, connect people with advocacy organizations, which I'll show on the next slide, support groups, social work. For language deprivation syndrome, this is going to be a multidisciplinary team here, as well as executive functioning disorders. So dizziness and balance. So, and you can have these issues with any type of hearing loss. If it is clinically significant, if a person has falls or they have a fear of falling is a big deal. It's as bad as social isolation. They need to be referred to ENT, vestibular physical therapy. You need to make sure they have no other neurological issues going on with their brain. And then self-advocacy skills, I think we're in our infancy for transitioning from a community-based to where we have better counseling and science-directed approach for teaching people how to advocate for themselves. Some of the great organizations are National Deaf Center. People have rights, legal rights under the Americans with Disabilities Act, and not everyone really understands how to use these rights. There are 10 regional ADA centers. They have absolutely great resources. So reach out, look at their website, Hearing Loss Association of America, National Association for the Deaf, Early Hearing Detection and Intervention, EDDI organization. So the key takeaway from the next two slides is I want you to be able to segregate patients into low and high complexity hearing loss. Low complexity hearing loss is something that can be managed in the community with you don't need a subspecialist. So high complexity hearing loss is the opposite. So this is low complexity hearing loss is about 97% of all hearing loss. I'm talking about adults here. And you're talking about gradual, progressive, non-fluctuating hearing loss. It's the same in both ears. You have tinnitus that is in each ear if it's present, and it's not pulsatile tinnitus like heartbeat or vascular. And people can talk on the phone easily with anyone using either of their hearing aids. So these types of patients are great for Costco. They're great for community audiologists. When you get into high complexity hearing loss, these people need specialized care. For most of them, I would send them to someone who is doing cochlear implants because that means that the audiologists are on top of things and fitting hearing aids appropriately. It means that the ENT is probably going to be more aware of the global issues around hearing loss. So primary care doctors do great at identifying sudden hearing loss. Most of the time I see failures in this is from the urgent care centers. And any painless unilateral hearing loss with pressure and the word blocked ear or congested ear is sudden hearing loss until proven otherwise. You can start steroids until they can get high-dose steroids like prednisone, 60 milligrams a day, until they get a hearing test. If people have intermittent hearing loss, like, my hearing goes out and then I wiggle my ear and it comes back, or they have asymmetric hearing loss and it's not obviously cerumen or middle ear fusion, you can use tympanograms for that. Even then, you probably should still send to an ENT. Pediatric hearing loss in the early critical period. When you start getting to adolescence, later adolescence, you can probably use community audiology. But I would still, but pediatric hearing loss in the critical period is, especially early on, is really, really important because time is really important. If you have to yell to people, there's talking loud, but there's yelling and getting close to people, they probably have a severe, moderately severe hearing loss or worse, and you probably should send them to consider them high complexity hearing loss. We've already mentioned struggling on the phone with hearing aids is definitely high complexity hearing loss. So hearing loss, my summary, hearing loss has cascading effects on communication, the brain, executive functioning. Treatment is undervalued and there is rampant care and opportunities for everyone to improve. And intervention as early as possible in hearing loss is critical for all ages. Remember, the ACHIEVE trial was 3 years. They were able to have the dementia within 3 years for high-risk people. In high complexity hearing loss is ideally referred to an implant center. And I don't mean like academic centers are backed up. There's like tons of wait times. There are more and more community ENTs who are doing implants now. So if you I do a monthly session on the first Thursdays, 5 p.m. Anyone, anywhere can come and ask questions about hearing loss. They don't have to be my patients. They don't have to be a patient with hearing loss. They can be family. So you can use this QR code and you can, if you have questions, you need to get in contact with me, you can text any of my numbers that are on my website. My assistant will get you right in contact with me. I'm just going to leave this up. I had my email over here, but I probably should have put it on the previous slide. So I'm going to leave that up in case people want to do that. Okay. Oh, wow. 9:50.
Thank you so much, Dr. Ruffin. I know most of us are on that 12:50 Eastern time zone. So thank you for a wonderful presentation. There's already a couple questions here. So why don't we go through in order? And I think, yeah, why don't we do these 2 questions? And I do have a follow-up question as well. So the first one, are you able to see the question? Do you want me to read them out?
I can't bring my Zoom thing up, so reading them out would be great.
Yeah, no problem. So first question is, would one potential response to parents who are reluctant to give their cochlear implants to their kids is really around the fact that they may be, that the implants might give kids choices of different ways of communicating. They can always take the cochlear implants off if they don't want to use spoken language or spoken communication, but if they don't do the implants, they won't have as many choices regarding communication.
I think that's a great, I'm gonna repeat to make sure I heard it right. So basically, is it okay to tell kids with that it's okay to get an implant and then they have maximal choices? Yes, I agree with that. If you have an implant, the later you get a cochlear implant, the worse the outcomes are going to be. And I think that's a great way to look at it. You can always stop using an implant. You can always learn sign language at any point. The organization that Dr. McKee and I are in, Association of Medical Professionals with Hearing Loss, there are a ton of people who are have congenital hearing loss who transition to using sign language to improve their access. So it's a great tool. So there's no cure for hearing loss. Having the most tools is the best way to approach it, I think.
Yeah, I think this is also related to this topic. So how do you reconcile your answer to the last question with emphasizing urgency of intervention in the early critical period, as you suggested in the pediatric population? I'm unclear how to emphasize urgency while respecting family wishes.
So the thing that stuck out to me was reconciling, because we talked about earlier with the deaf family, capital D deaf signing family versus this one. So 95% of children with hearing loss are born to hearing parents, and the acquisition of language is likely going to be listening and spoken language. That's what the language native to the family is. To learn another language rapidly and be very proficient in it is not very I don't think it's very likely to ask a busy family to do that. So I kind of lost the question here. So what was the question again? Sorry.
Yes, how do you reconcile your answer to the last question with emphasizing urgency of intervention in the early critical period, as you suggested in the pediatric population? I'm unclear on how to emphasize urgency while respecting families' wishes.
Oh, I would just tell them, if you delay treatment by 3 months, intervention by 3 months, 6 months, you can pick that change up 12 years later. That means we can see decreased academic performance, decreased language acquisition. I don't know how to other emphasize. You can ask the parent directly, like, what are your reservations? You have to meet them where they are and try to address their fears. some of it's going to be denial and the grief process, and there are 5 stages to doing that, you know? So addressing that, bringing them back, perhaps. I honestly don't know how to do it other than that. And scheduling appointments with the audiology for follow-up. You can put them into contact with other parents who have children with hearing loss. So
Great. I do have a question. So this is probably very pertinent to primary care providers across the board. So many audiologists obviously are in the community, and often we do not get input or feedback. And so there's a little bit of a disconnect, not great communication between hearing health professionals and primary care providers. How can we address it? And what are things that we can do in tandem? So for example, fall risk, you talked about cognitive decline. Are there additional testing that we should be jointly doing or managing together?
I am not the best person to ask for screening for dementia. There are multiple ways of doing that. I believe there's the McKee or something like that. So you need to manage the risk factors. How using the existing ways that you screen for dementia already that primary care uses is I would recommend doing that. There are some in-clinic questionnaires. I can't remember off the top of my head, but it's on the tip of my tongue. But in terms of audiology, I probably would recommend patients to bring a copy of their hearing test, bring their records with them, emphasize with your front desk staff that they do this. If you send a patient to an audiologist, have the patient come back like 6 months later, see where they're at, how they're doing with their hearing aid. So hearing aids getting a pair of hearing aids is not like riding, is not like putting on a pair of glasses. I tell patients it's more like riding a bike. It can take as many as 7 visits to get everything straightened out. And a lot of patients don't have that kind of patience. So I think that just bringing people back and treating this more like, I'm sure you have to bring patients back for cardiovascular stuff when they've had heart attacks and stuff like that. Treating it like that until people are up and running with their hearing aids is probably the way to go.
So we have time for one more question, and I'm going to read it out. So what treatment options would you recommend for patients without insurance who now have adult onset hearing loss? How well do over-the-counter hearing aids work?
So over-the-counter hearing aids, the last time I saw the evidence, they work just as well for mild and moderate hearing loss. They work just as well as prescription hearing aids. If they're, if you get a good pair of OTCs or PSAPs, you can think of the AirPods with hearing aid function as a PSAP, personal sound amplification product, even though I think it meets the standard for OTC hearing aid. So those are totally fine, I think. The Lions Club collects old hearing aids and dispenses them out. You can talk to community deaf action centers. They often have sometimes may have resources. For example, I partnered with Hearing, Speech, and Deaf Center. That's where my clinic is located in Seattle. And they have loaners that they can give out. They have a special program for low-income people. So, but OTCs and PSAPs are definitely okay.
Thank you so much. So this was a wonderful presentation. Dr. Ruffin, thank you for joining us. I also want to thank everybody who joined, and also thank you for the 2 interpreters, and also Anne for captioning today. And thank you, last but not least, Liz and Dawn for helping getting all of this set up. So thank you.
Thank you. I appreciate the invitation.